are ready, I'll go ahead and kind of just get the meeting started then. Perfect. Well, thanks again to everyone for joining on the call today. We love having everyone each month and having the opportunity to, spotlight people across our state who are doing the work to improve infant maternal health outcomes. And so today, we are going to be joined by some folks from the Department of Children and Youth, which the agency is like a newly created agency in the last year or so. And so we have Allison Payton. She is the Bureau Chief of Maternal and Early Childhood Services and Support. And then we also have Dana Mayer, which she is the Manager of Maternal and Infant Clinical Initiatives with the department as well. So big thank you to you all for being here again. And if you both want to go ahead and just get started with your presentation, that would be wonderful. And sorry, real quickly too, at the end, we'll have time for question and answer. And as always, you can find that at either the bottom of your screen if you're on a laptop, top of your screen if you're on a phone. So feel free to put stuff in the chat there if you have questions, like even during the presentation. So thank you so much.
Well, thank you so much, Deja. I feel like this has been a long time coming that you and I have been working together trying to select a date for us to present. So we are excited that the date has finally arrived. And good afternoon, everyone. And thank you so much for having us today. As Deja said, my name is Allison Payton, and I serve as the Chief of the Bureau of Maternal and Early Childhood Services and Supports, alongside my colleague Dana Mayer, who's the Manager of Maternal and Clinical Initiatives here at DCY, who you all will hear from shortly. We are thrilled to be in this virtual space with you all today, talking about a topic that is a top priority for the Department of Children and Youth as we seek to improve maternal and infant health and wellness and to reduce the numbers of pregnancy related deaths and infant mortalities in our state. We at the department know that in order to do what's right for kids, you have to start by taking care of mom, addressing her needs and supporting her overall health. So during this session, Dana and I will talk with you all about the various programs that we have in place here at the department and how we, alongside a team of dedicated professionals, are working every day to improve outcomes, reduce disparities, and better serve the moms and infants in our state. So with that, I believe Dana is pulling up our slide deck and she will kick us off.
How's it looking, friends? Looks like a full presentation, not like half a screen with some notes. Oh, we're halfway there, y'all. Good start. Okay. Good afternoon, everyone. Dana Mayer. I'm the manager of maternal and infant clinical initiatives. All that means is I have the great privilege of working with a group of brilliant humans who really get to think about what are the intervention strategies, skills, core competencies needed when it comes to our clinical stakeholders. So that's the providers, the institutions, the systems that are responsible for making sure that mamas have safe, healthy, equitable, respectful, compassionate pregnancy experiences. And have a similar experience in their postpartum period, and then also making sure that babies and their families have a similar supported experience to reach their first birthday. So really honored and grateful to be here. I'm going to start with some data, and certainly data can be heavy, but I think it's incredibly important to ground us in why we're here and why we do this work. So part of the work that I and the brilliant team at DCY have the great privilege of doing is thinking about our Pregnancy Associated Mortality Review Committee, or better known as PAMR. That may be what you're more used to hearing it called here in the state of Ohio. So what is the PAMR committee? PAMR is Ohio's Maternal Mortality Review Committee, which is a surveillance program responsible for monitoring maternal mortality throughout the state. Maternal mortality review committees are a national infrastructure. They're a national standard set by the Center for Disease Control and Prevention. And they're intentionally designed as the gold standard for gathering, analyzing, and understanding pregnancy-related death, with the goal of making actionable recommendations to make sure we can prevent any of these deaths from occurring again in the future. And so there are two key components to PAMR. There's first the staff that live here within the Department of Children and Youth, and they're responsible for the identification, abstraction, and data entry of maternal death cases. And then that's complemented by this multidisciplinary committee made up of members from a diverse set of disciplines and backgrounds. It's really important that we have both clinical and non-clinical representation on this team, because we know that a mom's experience isn't solely related to her healthcare experience, but it's really about what it was like to be a pregnant woman at that time. And so we have everyone from who you could expect, a maternal fetal medicine doc, all the way to addiction medicine, and we have social workers and a clergy member. So really trying to be thoughtful about how do we have representation on this committee that can really help us understand her experience and try to prevent these deaths from happening in the future. All of us come together, both staff and committee, to work to identify and review all pregnancy-associated deaths that occur in Ohio, with the sole goal of promoting systems change to reduce the preventable maternal deaths. So this little star is going to be relevant to you all during today's conversation, because every time, as I had mentioned, a big part of PAMR is making recommendations. How do we prevent these deaths from happening in the future? How do we use this data in an intentional way? And so today, a star on your screen will represent those interventions, those innovations that were designed directly in response to this data in an attempt to honor the women, their experiences, their families, and trying to do better for all pregnant women moving forward.
Hey, Dana, I'm sorry to interrupt you.
Yeah.
Your slides, we're seeing the slides with the notes. I don't know if we can start it from current slide
Yes, I'm so
so that we can see the
sorry.
large green. That's
Thank
okay.
you for saying that.
You're
I
welcome.
was not aware that that's what was happening. So let's try. Okay, are you seeing just slides now?
Something is coming up. So let's see what we got. There we go. Perfect.
Okay, sorry, y'all. Thank you
No
for your
worries.
grace and patience. Allison, thank you for letting me know. Nothing more obnoxious than seeing the image teeny tiny while you see my entire script. So, okay. Glad we have that right. And it's really important. Allison knew this slide was coming because there's a lot of text on this slide, but I think it's really helpful in understanding the process of PAMR, because it's a really intensive process, but that's what makes it so important to the type of data we are able to glean from the experiences of these women. And so this is a deeper dive into the PAMR process. There are 4 key steps. It starts with that green box on the right. And we really have to first identify all of the deaths. So PAMR staff use vital statistics data to identify all pregnancy-associated deaths that occurred to Ohio residents. So that means she died during pregnancy or within 1 year of pregnancy. And then staff request and obtain records from any facilities, providers, or offices that the decedent received care or services from prior to their death. So this includes, but not limited to, what you would expect. So we're requesting prenatal records, we're requesting hospital records or autopsy records, but it's so much bigger than that. We really try to build a whole picture. So there's also sometimes, for example, if police or investigative institutions were involved, requesting records from them, medical transport to understand how decisions were made about where and how she was taken for care, social services agencies. Sometimes we do have the opportunity to get records from Child Protective Services if they were involved in either that mother or that mother's family's experiences. We're really trying to build this understanding of her experience. And all of this information is used to create a de-identified case summary that describes the events that led to the decedent's death, to review by the PAMR committee. And the staff responsible for building these de-identified case summaries are our nurses. And in many ways, they're truly detectives. They invest an incredible amount of time and energy in working to respectfully and holistically understand the experiences of these women in their pregnancies, so that we can ensure when the committee reviews these cases that they really understand the holistic and complex experience that many of these women had. And so after we then take it to our committee and we review each death, what's really incredible about PAMR and different than some other surveillance programs are these 6 key questions that you see listed in that yellow box. We are always asking, was this death pregnancy related? And I'll cover definitions next because you've now heard pregnancy associated versus pregnancy related. We make sure they were pregnancy related. We identify what the cause of death was. We identify preventability and whether or not there were critical contributing factors. If so, what were those? And most importantly, what are recommendations and actions to address those contributing factors and causes of death so that we can prevent these from happening in the future? And then finally, we analyze all that data and disseminate that data and the recommendations with hopes that we can certainly prevent this from happening again in the future. So as I had mentioned, a few definitions. First is that overall umbrella. So sort of the largest universe of data is that pregnancy-associated death. So this is the death to a woman while pregnant or with 1 year of pregnancy, regardless of cause. So if she showed up in our vital statistics records, that's part of that larger universe or pool of deaths. And then under that umbrella, you'll see on the left side are what I referenced, the pregnancy-related deaths. So these are the deaths to a woman during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by pregnancy, or aggravation of an unrelated condition by the physiological effects of pregnancy. Essentially, the way this is simplified is if that woman had not been pregnant, would she still have died? If the answer is no, then this would be considered a pregnancy-related death. And these are the deaths you see in all of our reports. So the data I'm going to share is all from our 2020 report, which we actually just released a couple of weeks ago. And this is really about those women with which we had the opportunity to intervene and change her experience. And we really feel like that's our biggest opportunity for action and improvement. And then there's also these other deaths that would be considered pregnancy associated but not related. The reason we don't include those in our reports or make recommendations around those is because these deaths were not related to pregnancy. So these could be things like a motor vehicle accident, or if that mom had pre-existing cancer, for example, opportunities that certainly is a life loss, but in terms of preventability, we really feel like our opportunity for intervention is in that pregnancy-related space. And I hope I do justice to this on behalf of our incredible data, our data SMEs, but I'm sure you've all seen varying messages about the United States maternal mortality rates. And we just wanted to use this opportunity to really educate everyone on the differences in the data sources that are available. For estimates of maternal mortality at the national level, there are 2 main information systems. And so those are listed on the left of this slide. There's the National Vital Statistics System, which we will call NVSS. And there's the Pregnancy Mortality Surveillance System, or PMSS. NVSS provides information on maternal deaths in the United States and only includes death during and up to 42 days after the end of pregnancy. So that's really important to think about. That's a very different time frame than our maternal mortality data, which talks about pregnancy through up to 12 months after pregnancy. This data about NVSS is used really commonly to make worldwide maternal mortality ratios and comparisons, because it's something that we can measure globally more easily than some of these longer term measures. And then there's PMSS, and this began in the late 80s, and it provides information on pregnancy-related deaths, and it does include deaths during pregnancy or up to 1 year after pregnancy. This is the primary source of how the United States examines national trends and disparities in maternal mortality. So most frequently, this is likely the data source you'll hear about when we read those headlines around maternal mortality. For estimates of maternal mortality at the state and local level, as I had described, PAMR data, or state maternal mortality review committees, are really where it's at. They provide state and local level information about pregnancy-related deaths. This is where the depth exists. This is where we intimately understand the experiences of these women and provides the greatest opportunity for intervention, action, and response. And so I just think it's important to call out, we can't directly compare information from these 3 different sources. They're all trusted sources of maternal mortality information, but they're based on different data and they serve different purposes. And so I share that to say, when you read headlines about maternal mortality, just it's always important to consider, what's the data source? What's the measure of maternal mortality being used? And can I assess the methodology used? Again, PAMR is the gold standard. It is the depth. We intimately understand the experiences of these women and where and how we could have done differently. So just know we would love to be your partners in this as you're seeing things, reading things, and wondering, does that match what we're learning in Ohio PAMR? We would love to have those conversations and let you know if we have complementary data that could support answering that question with our state maternal mortality review committee data. But the one caveat being, as you can imagine, with the intimacy and intensive review process that occurs in PAMR, our data is delayed, and it's a challenge, and it's something we work really intentionally towards every day and every year, but we do recognize it's delayed. But would love to be your partners in thinking through, how do we intentionally apply the PAMR data in a way that complements or maybe considers consideration for what we're hearing at the national level. And so let's rock and roll into the data. You now know what the data is. How do we get there? And so, as I had mentioned, we actually just released the 2020 pregnancy related. So again, we just boiled it down to what were those deaths that were directly related to pregnancy and therefore deemed preventable. And we released this in the end of February, and it's important to note this only reflects a single year of data. So certainly there's some opportunity to think about 2020 individually, but it's also important to think about the trends that we've been seeing over time. But it's specific to the data from 2020. It was determined that 28% of pregnancy-associated deaths were determined to be pregnancy-related. And this means that the committee deemed if she had not been pregnant, she would not have died. And of those pregnancy-related deaths, 66% were deemed preventable. And again, Black women, sadly and disgustingly, for lack of a more appropriate term, Black women, again, were overrepresented among pregnancy-related deaths. Infection was the leading cause of death overall. It's really important to call out that COVID-19 for the first time was really included in these pregnancy-related deaths. So we did see a change in leading cause of death. And 45% of pregnancy-related deaths due to infection were deemed preventable. And inadequate risk assessment of risk was the most frequently identified factor that contributed to deaths in 2020. And this is where I talked about trends. So instead of just looking at that single year of data, this gives our trends over the last 12 years. It's not a surprise, maternal deaths are increasing in Ohio. They continue to increase. The maternal mortality ratio. So that helps us really measure for some of those changes in the denominator about how many babies were born or what do population shifts look like. When we look at it as a ratio, it continues to rise. And as you can see, mental health conditions was the leading cause of pregnancy-related death from 2008 to 2020. Important to call out that this included those deaths due to substance use disorder and overdose being the primary cause. Others in this category are depression, anxiety disorder, and other psychiatric conditions, but this is really a reflection of substance use in Ohio, and followed by other leading causes such as infection, cardiovascular conditions, embolism, hemorrhage, and hypertensive disorders of pregnancy. But I guess the silver lining is that with this capacity, we can use this data to help us understand how do we prevent maternal deaths moving forward, and what should our interventions be responding to. Also think it's incredibly important to recognize that when we disaggregate data by race and ethnicity, the leading causes differ between groups. So you'll see in that blue box, that is the representation of non-Hispanic white women. Mental health conditions, including substance use and overdose, were the leading cause for white women. But for Black women, it was different. Mental health wasn't even on the list. It's infection, cardiovascular and coronary conditions, hypertension, embolism, hemorrhages. And then for Hispanic women and other races other than Black and white, the leading causes looked a bit more familiar of that of Black women as well: hypertensive disorders, hemorrhage, infection, injury. This data is really important because it helps us understand how we should be responding and how our interventions need to be unique to each of the populations experiencing disproportionate burdens of death. And this is not news to you all, but I will never stop sharing this slide that it's critical that we raise the unacceptable disparities that are existing for Black women. We talk about this a lot when it comes to Black babies, and we see something similar for Black moms. The Black maternal mortality crisis in Ohio is real. Black women are almost 2 times more likely to die from pregnancy-related causes than their white counterparts. And it's really striking to me when we think about when these deaths are occurring. So as you can see, the majority of deaths, so if you look at those green and those blue boxes combined, 64% of pregnancy-related deaths actually occur in the postpartum period. I'm always struck, particularly around, say, like the Thanksgiving table, when I'm talking to my family about this work, and they always assume, well, death occurred during maybe labor and delivery or pregnancy. That's not what we're seeing. We have to be responsive to moms and care for her and love on her beyond into that postpartum period, because we know that's when the majority of deaths are occurring. And this statistic, to borrow the words of our PAMR coordinator, is the true call to action. Over the 12 years of 2008 to 2020, 68% of pregnancy-related deaths were deemed preventable. There's so much opportunity to do better for Ohio's moms, and we just must. We have to. And so let's talk about our attempts to do better. We do have a few federal main sources of support that allow us to do this work here in Ohio. We were able to use our PAMR data and recommendations to apply for and secure these federal grants. We have the National HRSA Maternal Health Innovation Grant. We were just re-awarded 5 additional years, so really grateful to continue to work with the incredible partners in Ohio about what are we going to do for the next 5 years to help improve outcomes for moms. We have the CDC Enhanced Reviews and Surveillance to Eliminate Maternal Mortality Grant. This is really specific to strengthening our PAMR efforts, improving data processes, quality, timeliness. So continue to be grateful for these resources. And most recently, we were awarded the HRSA Alliance on Innovation in Maternal Health Capacity Grant. This supports us in implementing our AIM patient safety bundles, which I will talk about here in a second. This is just a slide that's kind of the precursor of what Allison and I are going to get to talk you through today around, okay, you've talked about the data. You say you're being responsive, but what does that look like in practice? And so we've worked to secure the funds, and now we get a chance to share with you what is it that we are doing. And as a little reminder, the little star on your screen is going to say, hey, this is a direct response to what PAMR data and recommendations told us. So we'll start with our Ohio Council to Advance Maternal Health, more commonly known as OCAM. This is a statewide maternal mortality task force, and it consists of stakeholders from a variety of organizations who have come together to identify gaps and needs in Ohio's maternal health. We have over 100 individuals from 50 plus organizations. They assisted 5 years ago now in creating a strategic plan. We're in this period of evolution, if you will. 5 years just feels like yesterday, but it also feels like eons ago. The landscape is ever changing. So we are at the point where we're working with our members to identify what the next 5 years look like. But this is really the place in the space. As you all need information, as you all need access to the subject matter experts who do this work, we would love to open OCAM to each of you as an access point. If you're not already participating but would like to, the OCAM email address is on this screen. We would love to have you join us as well. Another PAMR response is the Compassionate, Accountable, Respectful, Equitable, or CARE for short, Maternity Quality Improvement Project. And so as you can imagine, a direct recommendation that Equitable care, equitable maternity care influences maternal outcomes. So CARE seeks to improve equitable maternity care for pregnant women and their partners by supporting maternity providers to, it's really about building skills and capacity, learning from one another. How do we do this work differently? And so partnering with institutional and maternity care leadership for supportive systems changes to improve compassionate, respectful, equitable care. Thinking about stratified data, how do they improve the accuracy and review of their data? So collection of self-reported data, making sure that it's good quality data coming in, and then how do they really use that data to guide improvements? It's really about how do you hear patients? What does patient feedback look like? How do you do that safely, equitably? And then how do you share ownership in design of co-producing responses with your patients, with your communities? This work is in partnership with our Ohio Perinatal Quality Collaborative. We just moved into, we just finished up the learning community, so really excited to learn what it is that we get to do in actual pilot implementation of what each of these sites learned during the learning community. As I had mentioned briefly before, the Alliance for Innovation on Maternal Health, better known as AIM. What is it? It's a national quality improvement initiative to support best practices that make birth safer and improve maternal health outcomes, and most importantly, save lives. Patient safety bundles are a structured way of improving processes of care and patient outcomes. They are clinical condition specific. They follow evidence-based structures that, when performed collectively and reliably, have proven to change patient outcomes. The goal of these bundles is to improve the way care is provided in an effort to save lives and improve outcomes. Every bundle is focused on actionable steps that can be adapted in a variety of facilities and resource levels. This theory that, okay, at the national level, let's provide an infrastructure that if every hospital adapts this and does this well, in theory, we should be able to improve outcomes and save lives. And so currently Ohio is implementing 3 of these AIM patient safety bundles. We landed on these bundles specific to the data. We looked at the leading causes of death and as well as the preventability of the leading causes of death. Where was our greatest opportunity for impact? And where we landed was that hypertension and hemorrhage were the first 2 bundles we rolled out because they were 2 of the leading causes with the highest preventability. And then most recently, we just rolled out the pregnant and postpartum people with substance use disorder bundle that just kicked off last year. From 2017 to 2018, half of all pregnancy-related deaths were due to mental health conditions. So that really became the impetus with which we said, we have to do something. And we knew that the AIM patient safety bundle infrastructure existed. And so we were glad to have the support and resources from the feds and some GRF to go ahead and get this off the ground. So wave 3 of this, wave 1 of the SUD work just kicked off with 23 hospitals. So we're really excited to see where this grows moving forward. And then we also saw a pretty decent transition in the number of deaths due to infection. And so in 17 and 18, the second leading cause of pregnancy-related death was infection, which was a shift. And so we really wanted to think about what can and should we be doing in response to this data. And so we are gratefully enough, we're able to just secure a contract to begin the planning of a sepsis bundle intended to kick off later this year or early next year. And so we've been implementing AIM for a little bit, but some really exciting things to share about the buy-in of our partners in our maternity hospitals. So we started with the hypertension bundle, and 84 out of the 91 birthing hospitals participated, which I think is really impressive. 86% of Ohio birthing hospitals are participating in the hemorrhage bundle, which is in wave 3 and wrapping up right now. And we were able to kick off the SUD bundle with 23 hospitals. And that SUD bundle is big and burdensome, as you can imagine. Responding to hemorrhage or hypertension feels a bit more tangible. You know what to offer at what frequency, with what information, but substance use is a whole different experience and design. And so just really grateful to those 23 hospitals for joining in on this response. Urgent maternal warning signs. I know this is not new to any of you, but excited about the opportunities we have in this space. So speaking of timing of death, we know again, the majority of deaths are occurring postpartum. And that we knew from PAMR that educating providers and patients on recognition, treatment, and prevention of obstetric complications is an opportunity that we have. We previously developed a quality improvement project around educating providers, pregnant women, and communities on the urgent maternal warning signs. We were able to provide written and verbal education and resource materials in existing public health settings to reach pregnant and postpartum women during their antenatal and immediate postpartum period. So as of this point, actually all WIC clinics in the state have providing urgent maternal warning signs as a statewide objective, which is amazing. So we know every woman coming through WIC is intended to receive urgent maternal warning signs education. We were able to educate 28 home visiting providers in 22 counties on the urgent maternal warning signs. And really just continuing to think about, what does the future of urgent maternal warning signs in Ohio look like? Confident the CDC's incredible materials are something you're intimately aware of, but just putting them on here in the event they are new to anyone on this presentation. The CDC has a beautiful campaign called Hear Her Concerns. It is really about the fact that, yes, knowing the urgent maternal warning signs is part of the response, but unless we hear mom, unless we respect and value her opinions about her body and what she's experiencing, nothing's going to change. So they have brilliant videos, discussion guides, pamphlets, posters to talk about what are the urgent maternal warning signs and how do we show up for mom? Whether we're a partner, we're a provider, we're just a best friend, or a pastor, what is the role that we can play in this work? So continue to drive folks in that direction. Taking a deep breath. I hope you all do the same. Thank you for hanging with me. Just really excited to share all of this work with you. So we'll then transition into obstetric emergency simulation trainings for emergency medicine providers. Going back to the PAMR data, we knew that from 2008 to 2018, 24% of pregnancy-related deaths in Ohio occurred in an outpatient or emergency department setting. Wild. That data always strikes me as such an opportunity. And for that exact reason, the team created a project around simulation trainings. We completed a needs assessment and a survey of delivery hospitals throughout Ohio regarding participation in simulation trainings. 98% of the hospitals who responded to the survey stated they do not conduct simulation trainings to prepare for obstetric emergencies. So this was our chance. How do we make sure that no matter where mama shows up, whether it is a birthing facility or not, that those doctors know how to take care of her in that emergency room? They have the skills, they have the knowledge to make sure that she receives the care that she deserves. And this is part of that process. So won't get too deep into this, but here are just some achievements. Would love to talk with each of you more about this project. But we have provided training to date to over 488 providers across the state, really focusing on those maternity care deserts. How do we really close that gap where we lack the care that mamas deserve? We have our Disparities in Maternal Health Community Grant. This is the closest to just the grassroots work that I have the great privilege of being connected to, and I adore it with my entire soul. PAMR was clear to us that contributing factors of maternal health disparities are so much bigger than any one clinical cause. It's about the experience of being a Black woman in this country, and that community knows best on how to respond. And so this is really a flexible pot of money that says, you know the women in your community best. You know her unmet needs. You tell us what the response needs to be. And so we have the great privilege to fund 3 community-based organizations to do work really specific to women, Black women in their communities to try to reduce the disparities. And then quickly, two final projects I want to share. Focus on Me is a shared collaboration with Medicaid and mental health and addiction services. It's a project that improves mental health care for reproductive age women. So, not just pregnancy, not just postpartum, but really thinking from a prevention lens. All women of reproductive age, they could be pregnant or postpartum, but enhancing our depression and anxiety screening and treatment in primary care settings. So, really trying to build an infrastructure, a system which values our women and their mental health in a way that supports her in having a healthy experience, whatever path that she chooses. And then somewhat aligned, Care to another collective project with our colleagues at Medicaid. But the goal of this project is to improve maternal and infant health during the interconception period by addressing maternal health tobacco use, family planning, and infant safe sleep during those pediatric well visits. So trying to think about, we know mama is more likely to show up for baby well visit than she is for her postpartum checkup because mamas take care of their babies first. And so how do we make sure that we're building an infrastructure that mom can be cared for in that setting too, where possible and appropriate, in the event she's unable to get to her postpartum visit? Medical legal partnership is a small pilot, not meaning that it doesn't have an incredible base of evidence both nationally and here in Ohio, but we do get to fund some of this work specific to Black infant and maternal outcomes. We were able to put out grants to both Metro Health and Nationwide Children's to support their medical legal partnership programs focused on providing medical legal partnership services to their pregnant mamas and their newly parenting families, specifically Black families in communities with greater rates of poor birth outcomes. And just these individuals are incredible. This work is phenomenal. I'm excited to see what we learn, but a lot of evidence and promising practice when it comes to when we talk about addressing the social determinants of health. What does it look like and mean to really embed clinical services with legal services in a way that just contribute to better health? And finally, I this is not work of DCY, but something I wanted to make sure was raised in today's conversation. We all know Black birthing persons are at a higher rate for perinatal depression and anxiety, and they're less likely to have their systems addressed with quality, responsive care. However, mental health screening providers have not been resourced with mental health screening and referral guidelines that really consider the cultural context and the lived experience of Black communities in Ohio. And so our partners listed on the screen said that's not good enough. And so they developed this framework of culturally responsive screening with the Ohio Perinatal Mental Health Task Force. And it was created in collaboration with Black birthing people, Black birth workers, perinatal service providers, and POEM, which you may be familiar with out of Mental Health of America, and a literature review and primary data from the focus groups and interviews with Black birthing persons and birth workers really informed these recommendations. And there's a full protocol that they designed and a one-page resource for those who may deliver mental health screenings to Black birthing women. They're free, they're publicly accessible, but I think this is such a beautiful data to action response about how do we just show up better and differently for our Black mamas. You all are exceptional, and I appreciate you giving me a chance to share. And with that, I will pass it along to my colleague, Allison.
Well, thank you so much, Dana, for grounding us in what we are doing in the Maternal and Infant Clinical Initiatives Program section here at our agency. We really want to give you all the full picture, so we thought it was important to really start out this presentation by providing an overview of maternal health, and felt that the next portion of our presentation should focus on the strategies from our maternal and infant community section, as well as some of the other scopes of work that are helping us to get closer to our agency's goal of reducing infant mortality. So as you can see on our screen here, one of DCY's big goals, the big three goals as we call them, is to reduce the rate of infant mortality in our state from 7.1 to a rate of 4.4. Our team and our agency, we know that this is a big goal, but we truly want to make sure that no infants in Ohio are dying of preventable causes. And so we feel that it's necessary to aim high. And aiming high means that we need to look closely at all of our programs to determine what is working so we can do more of that and build on it, and to assess the things that we need to do differently to help us reach and achieve this goal. And so we wanted to share this next slide to make sure that everyone is working from the same understanding about the infant mortality rates that we're seeing here in our state. The infant mortality rate is the death of an infant before his or her first birthday. It's the number of infant deaths that occur per 1,000 live births. The infant mortality rate not only serves as a key indicator of maternal and infant health, but is also an important measure of the health status of the community. So the overall rates remain above the Ohio 2028 State Health Improvement Plan, which we call our SHIP, goal of 6.0 per 1,000 live births. And the Healthy People 2030 objective is 5.0 per 1,000 live births. And you can see that we haven't reached either one of those, and we're going to be a little bit more aggressive in aiming for a rate of 4.4. Additionally, and important to call out, the non-Hispanic Black and Hispanic rates increased in 2023, while the non-Hispanic white infant mortality rate did not change. We want to keep that non-Hispanic white infant mortality rate low and get it lower. And we also want to bring down those high rates that we're seeing amongst our non-Hispanic Black and Hispanic infants in Ohio. And so the data on this slide shows the leading causes of infant deaths, because you see the infant mortality rates and you wonder what is causing these infant deaths that we're seeing here. So this slide indicates that the leading cause of infant death is associated with prematurity related conditions. So 28% of infant deaths are accounted for through prematurity, followed by congenital anomalies, external injuries, obstetric conditions, sudden unexplained infant death syndrome, and et cetera, as you can see here on your screen. Now that we've seen the data, the question that often follows is, why are we seeing the numbers that we are? What's contributing to the poor outcomes for moms and infants? And we know that's a great question. And part of that answer really goes back to what has been shared so far. We certainly can't talk about infant health outcomes without truly asking what is happening with mom. And to take it a step further, not only mom, but also dad, family, the village, and the community. So as a result, we really like to share this pie chart here that you see now, which shows some of the primary drivers of health outcomes and the factors that influence all of our health. And so this chart highlights for us that multiple factors really do play a role in our health. Things like clinical care, which would include healthcare quality and access, or a lack thereof. Individual health behaviors such as tobacco use and nutrition. And then finally, you'll see the largest percentage of the factors that play a role in our health outcomes is social, economic, and physical environments, which consists of things like housing, transportation, education, employment, income, and even air quality. And so, while that may be surprising to some, we know that the social factors account for a large percentage of the things that influence our health outcomes. And so, it's important to note and recognize that not only the things that I just listed and that you see on our screen here influence our health, but we also know that a big contributor to the stark racial disparities that we see in maternal and infant health outcomes, and the things that really drive inequities, are things like poverty, racism, discrimination, trauma, violence, and toxic stress. So now that we've reviewed the data and talked about the things that influence health, I'll move into some of the key strategies that our team and partners are implementing to address these factors and to help drive down the rates of infant mortality. And so, as you heard from Dana's slides, our agency really distributes a lot of money for grants and contracts, but we also work in partnership with multiple statewide groups. These groups help to support the alignment of state and local efforts that address maternal and infant health. The statewide groups are listed here. I'll talk about the Eliminating Racial Disparities and Infant Mortality Task Force in the upcoming slide. Dana already shared with you all about the work of OCAM, but one that's listed here is OCPIM, which is the Ohio Collaborative to Prevent Infant Mortality. That's a statewide partnership for community engagement, exchange of best practices and ideas, data management, and advocacy, which is focused on reducing infant mortality in Ohio. Some of our local partners include health departments and community and faith-based organizations. We have multiple sub-grants and contracts that are intended to try to build local capacity and ensure that we're learning from our local experts who are doing this work in the community and doing this work well, so that we can scale that work. Community partners are engaged throughout these statewide groups, and through our subrecipient grant programs. And so the first statewide group that I want to talk about is the Eliminating Racial Disparities in Infant Mortality Task Force. So back in December of 2020, our governor announced that he was establishing this task force and charged him with the goal of developing a statewide strategy for reducing infant mortality rates and the elimination of racial disparities by 2030. The purpose of the task force, as you can see on your slide here, was really to provide Governor DeWine with actionable recommendations on eliminating the racial disparity in the infant mortality rate. He charged this group with creating a roadmap to guide Ohio to meet the Healthy People 2030 goals for all babies, which would be 5.0 per 1,000 live births. But you've heard me repeat over and over that we're striving towards 4.4. He wanted Black women, families, and communities to be engaged throughout the entire process from beginning to end to ensure that the recommendations are grounded in reality. And so the biggest question that many members had about the convening of this task force was, what's going to be different about this process? What was really going to begin to help us to get out of this issue of infant mortality, high rates of infant mortality and disparities, and especially when we think about Black infants. So as you can see, these are the things that we felt would make this process unique, is the focus being solely on the disparity for Black infants and families, the inclusion of Black families throughout the process, including the creation of a feedback loop on the draft recommendations. Also, a huge one is the priorities of the administration being aligned with resources to create a stronger infrastructure, and then a commitment to accountability and transparency through the creation of a state implementation team. And so the recommendations were assembled using the Healthy People 2030 Social Determinants of Health framework. Quotes from the listening sessions were analyzed, placed into buckets and themes, and then uh, we use the 5 different social determinants of health categories in order to list those out. One of the things that was different about this process, as I mentioned earlier, was the fact that there was a commitment to having this transparent group working on these recommendations, and that was the creation of our state implementation team. So, as you read the recommendations, which are available on our website, please know that this work is being implemented and thought about by all of our sister state agencies and key stakeholders who represent different departments, such as Department of Medicaid, the Department of Development, of course, the Department of Children and Youth, the Department of Health, Department of Education and Workforce. Department of Transportation is at the table, Department of Mental Health and Addiction Services, Ohio Department of Commerce, and the Ohio Department of Job and Family Services. We know that this work cannot be done in isolation, and we know this is an all hands on deck initiative, and we know that it takes everyone thinking about how we reduce infant mortality to get us where we want to go, which is to less deaths, infant mortality deaths in our state. And so this next slide gives us an overview of some of the specific work our agency funds, in addition to the work of our clinical initiatives team at DCY to address maternal and infant health. This comes from our community initiatives section here, which is responsible for distributing of funding for a wide array of grants and contracts, which include, but really is not limited to, infant safe sleep, perinatal behavioral health peer support, our Moms Quit for Two, our Ohio Equity Initiative, community and faith-based infant and maternal health support services, Queens Village, Babies First Bereavement, and OCPIM, as I mentioned earlier in the previous slide. I don't plan to go in detail about all of these programs, and I am tracking the time, and I know that we're getting close, but I wanted to give you guys a high level overview in the next few slides. So first, I'll quickly talk about the Ohio Equity Initiative, or OEI for short. Ohio Equity Initiative is really focused on working to achieve equity in birth outcomes. It's a collaboration that began in 2012 between the Ohio Department of Health and local partners to address racial disparities in birth outcomes. So as we talked about in the previous slides, unfortunately, we are seeing that Black infants in Ohio are dying at a rate of 2.6 to 3 times that of white infants. Population data is used to target areas for outreach and services in the 10 counties in Ohio with the largest disparities. One thing that we like to note is that these 10 counties accounted for 84% of Ohio's Black infant deaths in 2020 and 62% of all infant deaths. So on the map that's displayed on your screen, you can see the counties that are funded to conduct the DCY OEI initiatives. I'll move on to the next slide and talk about infant safe sleep. Due to an unsafe sleeping environment, we know that a baby in Ohio dies every 2 to 3 days, and that's on average. The American Academy of Pediatrics provides recommendations on infant safe sleep that are based on science and extensive research. We promote the A, which stands for the baby sleeping alone, the B stands for baby sleeping on their back, and the C stands for the baby sleeping in a crib. Ohio's focus is on lowering the infant mortality rate in every race and ethnic group. We currently provide funding to 30 organizations which serve 71 counties in our state. These organizations are responsible for promoting safe sleep practices and distributing cribettes or pack and plays, as most people know them as, and safe sleep kits in their counties. We provide these materials through a contract with Cribs for Kids. And this next slide just shows you the 71 counties in our state that provide safe sleep materials. The next slide talks about our perinatal behavioral health peer support program. To increase mental health, and we know this is something that Dana spent some time talking about in her slide deck. We want to be able to support expected and new mothers who are pregnant and who are up to 1 year postpartum. So we provide funding to 4 subrecipients that serve 5 Ohio Equity Initiative counties to provide peer support services. The research has indicated that women who experience a lack of consistent and accessible standard of care in the United States is due in part to a scarcity of qualified and financially accessible mental health providers. One way to address provider shortages within the fields of maternal mental health and addiction is through the use of a certified peer support specialist. These peer support providers support with phone calls, virtual visits, individual and group support. Peer supporters are also available to provide outreach to communities, meet individuals where they're at in their physical environments and within their treatment process. And they serve as a critical part of treatment teams and other support programs within their communities that they serve. I also wanted to quickly highlight our community and faith-based infant and maternal health supports program. We refer to this in short just as community and faith-based funding. It is used to expand access for community and faith-based organizations to implement community-level projects and address system gaps. Each of our funded projects are unique. We have 19 of them. All of the projects are intended to positively impact one of the 5 maternal and infant health outcomes that are listed on the screen. And the final program that I want to highlight and share with you all is also one of our newest, and it's our Family Connects Ohio. Family Connects is an evidence-based home visiting program model that supports families through newborn home visits and provides a mom and baby with a visit from a registered nurse around 3 weeks postpartum. FCO connects families to healthcare providers who help to nurture the whole family and support the mom and the newborn's health and well being. This program kicked off in the summer of 2024 and provides services to every new mom, regardless of income, about like I said, 3 weeks to 12 weeks after delivery. And there are some exceptions in some cases. The evidence-based program has no income requirements for families. Family Connects offers all families in FCO communities a nurse home visit after they bring their baby home. All families, including adoptive families, foster families, and bereaved families in FCO communities that are participating, are offered this home visit with this nurse. There's 4 components of the nurse home visit, and that includes assessment, which is when the nurse conducts a physical and mental examination, not only for baby, but for mom as well, discusses health history, and checks infant and mom's vital signs and weight. The nurse provides education. They cover topics such as infant care, safe sleep, pelvic floor health, postpartum emotions, and household safety. They also discuss lactation support. So discussions are happening on positioning, latching, how to increase supply, pumping, and bottle feeding. Referrals. Nurses And that's the biggest thing. Nurses are connecting families who they see, because this is a one-time visit, to healthcare and childcare providers, WIC, and other community resources. And so the goal is really to keep these women and these families on the continuum of care, whatever that looks like for them. So if they are eligible for a longer term home visiting or ongoing home visiting, or if there's another need that is identified during that visit, the nurse is making those connections and those referrals right there on the spot. And this program, as I said, is currently being offered in 11 counties that are listed on the screen, with plans to expand across the state in the very near future. Our goal is really to serve new moms and babies and help us get closer to our goal of ensuring that babies in Ohio live to not only see their first birthday, but well beyond that. And so I think that brings us to the end of our deck, and I apologize for kind of flying through my slides, but I wanted you guys to have, just an overview of some of the work that we're doing at DCY to try to really drive down these rates that we're seeing in our state. But with that, we'd like to thank you all for your time and attention, and we have at least 3 minutes to open it up for question.
Thank you so much, Allison and Dana. What an amazing overview of the work that you all are doing with Department of Children and Youth. I think it was super informative, and I just want to remind everyone that if you do have some questions, please feel free to put those in the Q&A box, and I will go ahead and get to those. We did have a few in there, so I will go ahead and just look at those. Um, let's see here. Well, I see, Dana, you did send some links um, into the chat and responded. I guess we just had two. We had Ophelia. She was just, letting everyone know that was a great presentation. And as someone who's a part of the Paymer committee, just the wonderful way you all were able to explain the work that you're doing. And then, Dana, I see that you were able to get back to Kendra on her question. And then about if you had any data on the age of moms at the time of death. And if this is something we need to share with everyone else, we can definitely get that to some folks. Um, excuse me. So then now we have a new question from Groundwork Ohio, Caitlin. It says, how can we get advocates, or how can advocates get involved? Is the Paymer committee accepting new members?
We just wrapped up, our wonderful Paymer coordinator has instituted for the first time ever an open call application for Paymer committee members. So it used to be kind of like, if you're known, you're known, but there wasn't really a mechanism to say, hey, do you think you would be, what can you add to this committee? So what we have started doing, this is our second year doing it, is an open call application. We build a profile that says, here's where the gaps are based on what we're seeing on the data, and here's who we're hoping we can help identify to fill those gaps on our Paymer committee. So we are actually in the process of onboarding. We onboarded 23 new members last year. We are onboarding 16 new members as we speak. So the process did just close for this year, but Caitlin, it will be iterative. We will open that application up every year based on what we identify as needs and gaps. And in the short term, though, OCAM, we're really trying to evolve and re-energize and think about what does OCAM look like. But we'll make sure that we continue to share and communicate those opportunities as well.
Thank you so much. And again, too, like if there's like links or anything that you all want to share with our office, then we can make sure to get that out to people so that they can have that information as well. And then Erica Gordon, she had asked, said thank you again for all the information. And then again, is there still opportunities for partnership? If so, may we have the contact? Again, we can get that information. I see, Dana, you're getting back with them right now, so we can get that information to you all. And if anyone else has any more questions, again, please feel free
I do have
to
a
put
quick
that in
question,
there.
Deja.
Yeah.
So Dana, the packages that you mentioned that you partner with hospitals on, I forget what the exact name of them was, but like the SUD and the hypertension, those like really the main determinants of um, maternal morbidity. I was wondering if one, you could remind us of the name, and then also I don't know if I missed it. Do you all also partner with like birthing centers? And is there something with the like state doula program where they can be trained on those as well? Or is it right now just exclusively hospitals with maternal wards?
Fabulous question. Thank you for asking. Quick reminder, AIM is what you'll hear them talked about nationally, but that stands for the Alliance on Innovation for Maternal Health, which comes out of the National AIM ACOG, the American Colleges of Gynecology and Obstetrics, is where those are designed and come from. And right now, they are just the national infrastructure supports these occurring in birthing hospitals. The way that the interventions are designed are really specific to what you would anticipate the different levels of birthing hospitals specifically to have access to and infrastructure for. So it's a great point. We have not, and I don't know that any state has identified how do we apply these, if at all, to other birthing sites. And then what would that mean to Ohio's most focused on certified nurse midwives, which are in hospital settings. So we reach them through that. But, you know, a nurse midwife or a doula, for example, I really think because there are specifically clinical interventions. Anyone who's a non-clinician, like our support, incredible birthing support people like doulas, it really speaks to those urgent maternal warning signs. Like, how do we educate her on if mom is expressing something feels off or different, or wow, she's bleeding a lot and nobody seems to be measuring it. That feels like a really ginormous problem. Like, I think it's a great point for those non-clinical, just advocate roles, whether it's partner or doula or you know, whomever, how do we educate them is not something we've explored, but we need to.
Thank you for that thorough answer and for reminding us of the name of that program.
If anyone, I know it's about 1:03, but if anyone has another question, again, feel free to either put in the chat or you can follow up with our offices. And um, before we go as well, I just wanted to do a quick plug for everyone. Some of you may have gotten the save the date from our offices regarding the upcoming inaugural Black Maternal Health Summit that we are planning to host here in Columbus. Senator Ingram, Senator Hicks Hudson, Amber, and I, as well as a few others, we've been working to plan this event. Essentially, you know, the Black Maternal Health Caucus originally had met in person, was having in-person meetings like basically what we're doing now, but in person. And with COVID, we transitioned online, etc. And it does allow more people to join, but we want to bring everyone together that's been doing this work and has joined these meetings for a long time to be in person again and just have an opportunity to bring all these people here to Columbus to network. We plan to have a legislative panel where members of the legislature are going to be there to maybe answer the questions of the providers, get involved. And then we also plan to have a panel of providers as well, maybe to just talk about their work, share their ideas, what's working for them, kind of just that exchange of ideas. I'm going to share my screen really quick to be able to show you all the save the date information, and then share that. So that should be on the screen now. The event is going to be on April 15th. It is an all-day event, essentially. We'll have breakfast, we have lunch, and it's going to be at the Ohio Chamber of Commerce right across from the State House. So if you all haven't gotten it, please let me know. I'll make sure to send it, or, you know, if there's other folks that maybe I just am not aware of, or maybe just didn't include in that, please share that. We also plan to live stream some of the panel discussions for the folks who aren't necessarily providers, but just join our meetings to like be informed. So those folks can still tune in and listen into that. So again, just sharing that with everyone. It's amazing all the work you're doing. So I think it's fitting to have us all together to be able to celebrate that and get together. So just wanted to put that out there for everyone.
And then just as we close out as well, on behalf of Senator Hicks Hudson, in her office, I also just want to say thank you to our presenters. Again, you guys did an excellent job. I personally felt very informed, and there were a lot of things that I didn't know going into this presentation. So it was nice to hear what you guys are doing over at DCY, because I know that there's a lot happening there now.
Well, thank you so much for the opportunity to be here with you all today and present, and we look forward to continued discussions with you all.
Thank you so much, and thanks for everyone that joined on today. Keep your eye out for more details about the event as well, and have a good rest of your day. Thank you.
Thank you.